Okay. Hey, Cindy, can you advance my slides for me after all?
I I can do that, Mark.
All right, thanks.
No problem.
Okay, so hey, welcome everybody. I'm glad to have you guys here. My name is Mark Panashevitz, and I work with the National Association of Drug Court Professionals. Many of you have heard of us. Many of you come to the conference. I'm a project director with NADCP, and I work for the Veterans Treatment Court and then also the Tribal Drug Court Planning Initiative. Before I worked with NADCP, I was a clinical director of a 90-day tribal inpatient treatment program. And I've worked with TLPI for many, many years as a consultant. So that's me. So today we're going to talk about recovery management, helping people move from active addiction to lasting recovery. This is kind of a complicated subject, and I don't want to hurt anybody's feelings or offend anybody, but occasionally people don't like a light shined on them and they can get a little touchy about it. So we're going to look at a little stuff that people may not want to hear. So can you go to the next slide, please, Cindy? Okay, just like the disclosure that TLPI had to do, I have to do one also for the Bureau of Justice. And basically what this is saying is that if I say anything really crazy, they're going to say that wasn't from our office. And that's what the statement is. It's just basically saying that we're not going to hold the Department of Justice liable for any of this stuff. Okay, next slide, please, ma'am. All right, so what we're going to talk about today is addiction, remission, and recovery. The middle one there is a new term that many of you probably haven't heard yet, which is remission. And it kind of fills a gap on that point where somebody is in recovery and somebody is in addiction. So we're also going to talk about how people get better and what they've seen helps people get better. And it's going to go against some traditional beliefs. And we're going to talk about that too. And we're also going to talk about recovery management. Next slide, please, ma'am. Okay, so you see here we have addiction, remission, and recovery. So let's start with the first one. Go ahead, next slide, ma'am. Addiction. Okay. Hopefully everybody here realizes addiction is a disease. Oftentimes people get this really confused with choice. And I'm not saying there isn't choice when it comes to certain aspects of the disease, but whether or not somebody has an addiction is 100% a disease. And so I'm going to take a few moments to just kind of go over this and maybe give you some examples of different ways to think about addiction that maybe you haven't done in the past. So one of the first things we want to talk about is addiction is based on neural pathways. Okay? So when I talk about that, when I talk about neural pathways, everything we do is based on a neural pathway in the brain. So if I move my arm up like this, it's a neural pathway in the brain. If Jordan yells at me to stop doing something, it's because he's stimulating a neural pathway in his brain. When Cindy got all nervous because I might be late, that was also a neural pathway in the brain. Everything we do is based on neural pathways in the brain, and it's really important that you understand that. When we talk about addiction as a disease, the very first thing that I usually like to point out is let's talk about somebody that has had a stroke. And I know that that doesn't seem connected, but it kind of is. And we'll get to that. So oftentimes when somebody has a stroke, a blood vessel in their brain breaks. And when that blood vessel breaks, it damages, everybody should be going, neural pathways, right? Because that's what we've been talking about. Yeah, it damages neural pathways. And sometimes that damage can cause effects like people can't speak, they have a sag in their face, or they might not learn how to, they have to learn how to walk again, or they forget. And that's the point there. They might have to learn again. And so when somebody, let's say, loses their speech, we don't just write them off. We don't say, well, I guess you're never going to talk again, right? No, what we start doing is we start doing speech therapy with them. What we're doing inside the brain is we're creating a new neural pathway to bypass the broken one. And we do that by doing exercises and education and practice. And eventually the brain will form a new neural pathway and the person can start speaking more clearly. Now, for one person, that pathway could be developed in a month or 2 months. For somebody else, it might take 8 months. That's why when we look at people with addiction, that's why the rates of recovery and the way they go through recovery is so much different. It's because of that recreating a neural pathway, because basically what addiction does is bypasses logical thought. And so when somebody is deep in their addiction and they're doing all these things and you're going, oh my God, that's just crazy. That's because they're bypassing logical thought. And so it's not that they have a choice of doing logical thought. It's literally not their choice anymore because it's bypassed. Now, does that mean they're never going to have a logical thought? No. Occasionally one will trickle through and they'll be able to have it. But the majority of the time, they're bypassing logical thought. And our job as professionals and family members is to help them recreate a new neural pathway that will reconnect that logical thought again. And again, that might take some time. So when we talk about the addiction medicine, the American Society of Addiction Medicine, what they classify as the addiction, the very first thing is they've got to have a severe substance use disorder. Okay, it has to be a severe substance use disorder when we're talking about this form of addiction. The other thing is it's treatable, chronic, and it's also a medical issue. That's what we talked about when we started talking about the brain pathways and how they work. What we're basing that on is that medical part of this. Okay. Is it treatable? Absolutely, it's treatable. You know, just like reteaching somebody how to talk after a stroke, it's treatable. Sometimes it might take a lot of time though. We talked about brain circuits and neural pathways. Now, here's the next question I always hear. Well, whoever got into addiction, they're the ones that decided to use drugs first. You're right, they did. And that might have been a poor choice. However, I want you to honestly think about this. How many of us drank alcohol before we were 21? I'm willing to bet if I was in a room with you, which I really wish I was in a room with you, I'm willing to bet the majority of the audience would raise their hand and say that they started drinking alcohol before the age of 21. How old are we when our brains stop developing? Everybody should be thinking about that for a second, because when we do things when we're younger, guess what? You know how you sit there and go, oh my God, why'd you do that? You only have, what do you have, half a brain? Well, guess what? The reason why kids make some of the choices they make is because that's absolutely right. Their brain is not fully formed. And the last thing to form is the pathways for logical thinking. So if I start using substances at 14, guess what? You're right. I made a poor choice, but that's what 14-year-olds do, is make poor choices. That's where parents and capable guardians are supposed to step in and help out with that. And so you're absolutely right. Sometimes them starting the substance was a choice. But again, are we going to hold people to all their choices they made at 14, you know, or younger? I've seen people as old as 6 start with substance use, you know? And so that's one of those things I really want you to keep in mind, is that whether or not it's a choice, it really doesn't matter. And it always bothers me when people talk about that, because the only disease that we treat this way is addiction. We don't treat people this way who have high cholesterol. We don't say, well, you know what, if you weren't eating all that fatty steak, you wouldn't have this. And so we're not going to help you. And you just go off on your own and figure it out. We don't do that with people that have diabetes, you know. We give them medication. We try to do what we can. We give them education. We try to do what we can to help them. And that's what we should be doing with addiction. You know, it's a disease. And the quicker we can realize that it's a disease and the way it works, the better off we're going to be. Okay. This goes back to substances and other behaviors. Both of those tie in. And so I don't know if this gives any solace to people that have had to work with somebody that has substance use disorder. But a lot of times their choices and the things they do can be really, really incredibly hurtful. And at least now maybe you understand that is not intentionally hurtful. That it really is the act of these other behaviors, which often are based on compulsive behaviors and not a lot of logical thinking. And that's also the reason why oftentimes people with addictions, when they start getting their brain a little clearer, start feeling horribly guilty about choices they've made and things they've done. Almost every one of the people I worked with that had substance use disorder, when they started getting their head around straight, usually right around a month, that's when they started really regretting things that they'd done to other people. Now, is there harmful consequences for addiction? Absolutely. You know, and one of the things that I've always told people is that everything in life, there's a consequence. Everything. Now, sometimes consequences can be good and sometimes consequences can be bad, but everything we do is centered around a consequence. If I decide to eat less and start exercising, my consequence is I'll lose weight. If somebody else doesn't decide to do that, their consequence might be something harmful and happening. Just because we have a harmful consequence doesn't mean that that's the end of the road for us. It doesn't mean that we can't work through those consequences. And one of the things I'm going to come back to over and over and over again when I'm talking about active recovery, I'm going to keep coming back to this thing called hope. Because without hope, it is almost impossible to get into recovery. If I have no hope that my family's going to love me again, if I have no hope that I can do this, if I have no hope that my life can change, it's really, really hard to step away from that. So, and when we talk about this, the DSM-5, that's the little Bible for all mental health therapists, psychologists, and psychiatrists, we got to have at least 6 out of the 11 symptoms. All right. And I don't have all 11 symptoms listed, but you have to have at least 6 to be classified as having addiction and a substance use disorder. Okay. Do you notice the term there that I keep using? I keep switching over to this thing called substance use disorder. When I started in the field, it was addiction. That's what we said, an addict or addiction. And we're going to talk about a little bit later about why those words matter and why we're changing our language. But I want you to remember that we're going to switch that to substance use disorder. And part of the reason is because of that belief that there's a choice or a hope or a choice. And when we talk about substance use disorder, instead of looking at it as a disease. Okay. Cindy, can I have my next slide, please? Remission. Okay. Here's the gray area that we've always had. The gray area is I have substance use disorder. I've been using for the last 5 years. You guys can pick my drug of choice. It could be meth because that's the big one right now, heroin. Anyways, I finally go to a meeting. I go to an NA meeting and I see the light and I start changing my lifestyles and I quit using drugs. Well, now I'm in recovery. Except for a week from now, I'm back using. But as long as I quit again, I'm back in recovery. The reason why this is confusing is because of the word recovery. And we're going to talk about what true recovery looks like. But we're also going to talk about what remission looks like. And remission is when you step in and out of recovery. When you go into recovery and then step back out. Okay? And usually remission lasts a long period of time. Okay? And early remission, when you get into it, or when you're out of it, it's going to be at least 90 days. Okay. And long term is 12 months sustained. So one symptom may persist even in sustained remission. When we go into remission, so what we're trying to say is that instead of saying that somebody's in recovery, we're going to say they're in remission. So when they do that, when they stop for a day, they go into remission. When they stop for 2 weeks, it's remission. When they've been in it for 90 days, it's early remission. And when they've done at least a year, now we see sustained remission. Now, the question is what's the difference between remission and recovery? And that's kind of the thing we're going to talk about. So right now, I want you to think about some of the things that we've learned or heard in the past, particularly through 12-step programs and that kind of stuff. You know, a lot of times the belief around those meetings is that you shouldn't hang out with somebody who isn't in recovery. And so I would have clients go up and I would talk to them and I would say, well, who are you hanging out with? And they would list all these people off. And I knew these people were not in long-term recovery. They were still in remission because they would say, well, I'm hanging out with Joe. And I'll be like, well, how long has Joe been clean? Well, he's been clean 4 days. Well, I know that he shouldn't be hanging out with Joe because that's a bad idea, because Joe has just started remission and he's not in recovery. He's in remission. And the reason why I want to make sure we stress that is that we understand what the difference is. Okay. So I'm going to do a little experiment, but let's go to the next slide, please, real quick. Recovery. Okay. Before we go through this well-defined thing, I want to kind of go through what recovery is. So I want you as an audience to come on a little journey with me, okay? And this journey that I want to see you come on is I want you to go on a diet with me. Now, many of you probably don't need to go on a diet. Jordan looks like a little rail, so I don't think he needs to go on a diet. Me, I need to hit a diet up, okay? So I decided we're going to go on a diet together, all right? And what we decide is this. Our diet that we're going to go into is going to be called the Cabbage Diet, okay? Now, the rule of this diet is pretty simple. You guys are going to like this. The first rule is we're not allowed to weigh ourselves for 1 year. No matter what, we're not allowed to weigh ourselves for a year. Okay? And the next rule is the only thing we're allowed to eat is cabbage. Okay? We can have however much cabbage we want. We can have cabbage soup. We can have deep fried cabbage. We can have baked cabbage. We can have steamed cabbage. We can have any kind of cabbage we want. And that's all we get to eat, though, is cabbage. Now, I want you to think about this for a minute. So me and you are going into a bowling alley with all of our sober friends and hanging out. And they're eating hot dogs and chili and chicken wings. And we're sitting here eating cabbage. Is it difficult to stay on a cabbage diet when you have to do that? Do you think it might also lead to resentment when they sit there going, ooh, man, these chicken wings are good. Are you sure you don't want one, Mark? That's going to make it hard for us, isn't it? The longer that goes on, the more difficult it gets. But let's say we make it. We make it a whole year, okay? A whole year in this cabbage diet. And we hop up on the scales. And we haven't lost 1 pound. What's the next thing you're going to eat? Because I'm telling you right now, I'm not going to be eating cabbage. When we talk about recovery without change, go back 1 slide, please, Cindy. When we talk about recovery without change, what we're talking about is remission. Now, remission might be long-term. We might have none of the symptoms of substance use disorder, but if we haven't changed any aspect of our lives, if we haven't changed who we're hanging out with, we're still going to that bowling alley while we're eating our cabbage diet and watching other people eat chicken wings, or I'm still hanging around with people that are in active use or worse, in remission with me, but not in recovery, when nothing changes, it makes it very, very hard to continue to do that. And so that's what we're looking at, is we have to really understand when somebody's in remission and when somebody's in recovery. Now go ahead and go back to that next slide, Cindy. Okay, when we talk about recovery, I want to go through some of the things. The very first thing we see is change process. Okay, that means that we start doing things that are changing behaviors. And when I say change process, I mean wide sweeping changes. For example, not hanging out with people that are doing unhealthy behaviors. I had a friend, and I love him to death. He's a great guy. And I'll tell you a little bit of story about him. So he was addicted to meth, and he was hanging out with a young lady who was also addicted to meth. One of the worst stories I ever heard is they actually set up a tent in her drug dealer's yard so that it wasn't as far to go get their meth. It just so happens she decided to go to treatment, and she did, and she went into remission. Joe did not. Joe continued to use. When she got out of treatment, she was in remission, but she was still hanging around with Joe. Do you see the problem with that? She didn't change the people she was hanging around with. She was still accepting somebody in front of her using meth, or somebody that she knew was unhealthy and using meth. And then when I would talk to Joe, he would say, it's okay if I hang around with her because she's in recovery. But she wasn't in recovery. She was only in remission, because if she was in recovery, she wouldn't have been hanging around with Joe. A little bit later, Joe got into remission. Same thing. I asked him, who are you hanging around with? Hanging around with this girl who's still in remission. Do you see the problem with that? When we have a complete change, that's what we have as a change in behavior. You know, we have a change in behaviors. We have a change in the people, places, and people we're looking at. We have a change processes, an overall sweeping change. So when you look at somebody and they say that I'm in recovery, there should be certain things. And again, oftentimes what I see is I see long-term remission. And I'm not knocking remission, okay? Go ahead, Cindy, go back to remission real quick one more time. I'm not knocking remission. I'm not saying that people are horrible that are in remission. I'm not saying that they don't deserve hope. I'm not saying any of those things. But what I am saying is you got to understand the danger of somebody that's in remission, okay? Because symptoms can persist and they can come back, and you can come in and out of remission often. All right, and there's a huge difference between remission and recovery. And that's what I want to stress, is there's a huge difference between remission and recovery. Go ahead to go back to recovery again, please, Cindy. Health and wellness, that's another thing when we look at recovery. When people are in remission, oftentimes they still have the same kind of criminal thinking, they still have the same kind of criminal behaviors, and they also don't care that much about their health usually. Again, because they're not in recovery, that's not an issue. But one of the things that can happen when somebody's in recovery is they start worrying about their health. They start taking care of themselves. They might want to get their teeth fixed. And you notice the next one, abstinence. There is no more continued use. They're not around it. They're not using it. Okay? Abstinence is what we're looking for. Abstinence without recovery is that cabbage diet again. Okay? Because a lot of people can have abstinence. That's what that remission is. All right? So abstinence or recovery without abstinence is another form of remission. Okay? Or yeah, I'm trying to say it right. Abstinence without recovery is another form of remission. So that's one of those things we want to look at. Do you see the next one? Self-directed life. When I hear self-directed life, one of the things I hear is purpose. And I know how important it is to have purpose. I have worked with people that had some severe disability and they couldn't work, and they were just kind of in front of the TV a lot, and we couldn't figure out why they were depressed all the time. One of them was a young lady that had difficulty walking and stuff, and she was on Social Security disability, and she had chronic depression. She was depressed all the time. One of the things we suggested is her go to an animal shelter and just hold dogs, just hold puppies, just associate with puppies, get them used to people touching them. I'm telling you, her depression vanished within weeks because she suddenly found her purpose. And with that, she started working with shelters and trying to get it changed to a no-kill shelter. And she tried to do all these things that had nothing to do with a job. And I think that's a big problem, is a lot of times we associate job with purpose. And that's not necessarily true. And so when you give them purpose, you give them hope. That's what we're talking about. And you also give them the option now of having a self-directed life. And when I talk about that self-directed life, you got to remember that when they were tied with a substance, they didn't have a self-directed life. Their life centered around that substance, around trying to find that substance, around trying to avoid being sick, around being around people that use that substance. Yes, I do see that, Carol. I can see your questions, and you're talking about identity issues. People lose a sense of, I'll read it real quick. And I love it when you guys type in questions, by the way. Carol said, identity issues. People lose sense of former identity to recover, may leave recovery to go back to remission state to feel more comfortable with themselves and to feel real. Sad but true. Suggestions on intervention and acceptance of identity as part of recovery. Well, I'm going to get to that a little bit later, okay? And if I don't cover it at the end, remind me again to answer that question. But one of the things we're going to talk about is oftentimes when people, go ahead, Cindy, back to remission real quick. When people are in remission, that's where we need to start giving them the tools to help them get into recovery. Now, the choice. This is the part where we talk about choice, okay? We talk about creating logical brain neurons and neural pathways. And then go ahead and go to the next slide, Cindy, again, back to recovery. Cindy's probably like, Mark, I hate you. You keep making me jump back and forth. right there at the bottom where it says always a choice, that's when we start seeing choice. I have a choice if I want to take a chance and start meeting new people. I have a choice if I want to start living, being concerned about my health and wellness. I have those choices. Okay. And that's when logical thinking is starting to return, and when somebody does that. All right. And I love that part at the bottom, or second to the bottom, where it says personal condition, not a program. And again, I'm not knocking 12-step programs. I'm not. And I'm not saying working a program isn't a good idea, but some of the problem with that is sometimes we depersonalize it and we don't make it, when we have to understand that this is a personal condition. Okay. And again, there's all these choices that we can hold them responsible for, but just not that one choice about the substance use. Okay. Next slide. Okay. Recovery does not happen in isolation. So let's go back to remission real quick. That's 2 slides back, Cindy. There we go. Isolation is can be part of remission. Okay. I see this over and over and over again, especially in the treatment thing. And I think this goes back to that question about finding your own identity and all this and stuff like that. So the question was about somebody finding their own identity. A lot of times what people will do is isolate. They'll put themselves in a house or a room or someplace where they can't be, where there's nothing that can come around them, and then they stay there. Before I was a clinical therapist, one of my jobs was, for 8 years, by the way, I was a correctional officer in a level 5 prison in Michigan. I have seen inmates get tickets and get put into segregation. That's where they're isolated from everybody else, and they only get to go outside for like an hour a day. They have to eat in their cells, everything. I have seen men that were normal go crazy in isolation. You cannot do it. Isolation does not work. You might stay in remission while you're isolated, but you don't have any of those social supports. It's really hard to have hope when you're isolated. You know, that's why when we talk about some of this stuff, it's almost like when we talk about humane treatment of prisoners and that kind of stuff, isolation is one of those things that they found that we are human people. We need contact. If anything, COVID should have taught some of us that isolation can really, you know, put you a little bit on edge there. Go ahead and go back to the next slide. Go ahead, Cindy, you can switch it over now. Go to recovery and then one more. There we go. Perfect. Right there. So recovery doesn't happen in isolation. If you're in isolation, then you're not building any of those new tools. You're not learning healthy people to be around. You're not learning your purpose. You're not having a self-directed life. You're just in isolation. It's like hitting pause on a movie and coming back 2 months later. All right. That's exactly what it kind of comes down to. And that's the kind of stuff that we don't want to see, is that kind of thing. Okay, I think we can go to the next slide. Okay, now, hope. I'm going to say it again. Hope, 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 hope. And this thing called recovery capital. All right, we talked about remission. Now we're talking about recovery capital. So how do we get people in recovery? And more importantly, how do we keep them in recovery and not having them slip back to remission or active substance use? Well, we do that through what's called recovery capital. That means that they have to have enough capital to stay in recovery. Now, this is where I might get a couple people upset. All right. I know that there's this belief that for somebody to get sober or in recovery or stop using drugs, they have to hit rock bottom. Most research, all research that I know of, thoroughly disagrees with that. That when people hit rock bottom, it's actually much easier to stay at rock bottom. And that's why when we see people that are overdosing, guess what? That's that rock bottom. When you're at rock bottom and you don't have any hope, then it's really, really hard to get up and go forward, you know? And I know that that belief of letting them hit rock bottom, letting them feel the pain, let them, all this stuff. I know that's an old belief, and a lot of people are really invested in that. And I'm going to tell you that you will get more with support in recovery capital than you will by letting somebody hit rock bottom and suffer. Now, does that mean I'm saying enable them? No, I am absolutely not saying that we're going to enable them. I'm not saying that we're going to go out and buy their drugs so they don't go through sickness. What I am saying is we are going to give them support, and that's part of that recovery capital. So affirmation that they can do it. That's what we're looking at. We're looking at affirmation that they have the ability to do this, that they have the ability to go on this new journey. Okay, showing them people that have went on the journey and are successful. Advice. Yes, advice. That is a great way to start with support. Here's the deal. If they don't take your advice, don't get upset. Now, for all the therapists in the room, I know that we wish we had Jedi mind powers, so we could just look at our clients, or see, I use clients, and I'm going to talk about that in a minute too, our patients, and just tell them, stop doing this, and they would just stop doing it. That doesn't work that way, guys. We can give advice, we can give exercises, we can tell them ways to help them, but advice still comes down to the fact that it's up to them. And part of this horrible thing is realizing that we may have to give the same advice over and over and over again. Now, one of the things, and this is why I talked about it earlier, is remember that whole thing we talked about speech therapy and somebody that has had a stroke. I don't think we get to a point where we say, you know, well, I'm just not going to teach you how to do this anymore. I've taught you how to say the word dog 6 times and you're just not doing it. So I guess you're never going to use that word again. Let's move on. We don't do that. And so we need to remember that when we're giving this advice, they might not take it. They might do the complete opposite of what we want them to do. But that doesn't mean we stop and we don't keep continuing to work on that neural pathway, because that's what we do. Advice is helping that neural pathway. Now, accountability, absolutely. They need to be accountable for the things they've done and the things they have and the choices they make. Hopefully, if they're held accountable and they have consequences from that accountability, right? We talked about that earlier, that everything has a good or bad consequence no matter what. Well, we hold them accountable. But here's the point, and here's the danger of accountability. I love accountability. I think it's great. The problem with accountability is almost always we only focus on negative. When somebody has done something wrong or something that was damaging, we focus on them having to be accountable and take their consequence. We never look at the accountability of the things that they're doing right. Again, hope. Hope is going to be so much more important to you guys than hardness. Hope is holding somebody accountable. And frankly, it's just not fair, is it? I mean, here I am, I'm busting my, I almost swore, see, I'm getting better at that too, because I've been held accountable. I'm busting my butt, and I'm doing all this stuff right. And then I go and I hang out with George again, who's not in recovery. I don't do anything else but that, but then that's what you focus on. You don't look at all the other things I've done right, because we're not going to do that. Now, I'm not saying don't hold me accountable for George. Yes, hold me accountable. But if you're going to hold me accountable for the things that I've done wrong, you damn well better make sure you hold somebody accountable for all the things they've done right. And it may seem like a small thing, but every time you hold somebody accountable and give them positive consequences, you will get much further with positive consequences than you're ever going to get with negative accountability. Okay? Affiliation. The only way they're going to learn how to be around people that are healthy is affiliating with people that are healthy. One of the things that just blows my mind is when we have people that come in with substance use disorder and we expect them to be well-functioning people. That we expect them, that if we tell them, hey, listen, there's a job over here at the Quickie Mart, they're hiring people. If you go right there and get it, you'll be good. And then we stop. We just leave it up to them now. And then we're frustrated that they never called about that job. Well, guess what? When we have people that have substance use disorder and they've hit these rock bottoms, if you want to call them that, a lot of times they don't have confidence, they don't have good self-esteem. And when you tell them to go do something, they have no idea. They even if they've done job interviews in the past, it's probably been a long time, and they certainly probably haven't done one without being under the influence of a substance. And so think about how terrifying that would be to have to go do that again, and yet you're just going to throw it in their laps and tell them to do it. That doesn't work. You can tell them, you got to hang out with new people. You got to make new friends. Guess what? The way I've made friends for the last 5 years is by using drugs. I have no idea how to make a healthy friend. And again, I'm terrified because maybe that healthy friend isn't going to want to hang around with me because they're worried I'm not healthy. That's where we look at it. If you're going to tell them they have to make friends, then you've got to show them. You've got to give them a venue where they can meet people that are going to be willing to make friends with them and talk about what's going to happen when they try to make a friendship and it doesn't follow through. Because these are all these things that they still don't know how to do. And so when we talk about how do you stop somebody from slipping out of recovery, that's how. You stop somebody by giving them this new life and helping them build it. If you tell them, go build it, they're not going to do it. I'm telling you right now, I can't build a house. I can't cut a straight line. I'm horrible at measurement. All right. My soon-to-be father-in-law continually teases me because I can't do these little carpenter kind of things. Okay. If you look at my dog fence I built, it's not level anywhere and it zigzags. If you gave me all the materials and said, go build a house, even though I have the materials, I have no idea how to do it. And I'm just going to sit there and look at it. I'm just going to look at that stuff and go, well, I don't know what to do now. That's that part you've got to absolutely remember up here is that you have to make sure that you show them how to do it. If you want to keep somebody in recovery, you got to give them the tools and then show them how to use the tools. You can give me a hammer, but if you don't tell me how to build the house, guess what? I'm just going to sit there. You're going to have to come over, pick up every 2x4 and every nail and show me where it goes, show me how to swing the hammer, everything. That's the part that people keep missing. They get to this point where they just tell people to go do stuff, expecting them to be able to do it when they're not like us. They don't have those abilities because of the damage that's been done through the substance use disorder. And that also comes back to affiliation when we talked about that again. The more that you can have them affiliate with positive and healthy people that are in recovery, the easier it gets. Next slide, please. Recovery does not happen in the absence of hope. I'm telling you right now, when somebody hits rock bottom and they are hopeless, recovery does not happen. There has to be hope. There has to be something that they can look towards that's going to give them a chance. If they don't believe they can do it, then they don't have hope. If they don't think somebody's going to be there at the end of it, they're not going to have hope. Oftentimes they're using this stuff not because they want to use it. It's not fun. Taking heroin so I don't get sick is not a good time. And most of the time, they're not even getting high anymore. They're just using to avoid sickness. If you don't give me hope that something's going to change, then there's a problem. Now, hope doesn't mean fairyland, okay? It doesn't mean unicorns and rainbows. We're not going to tell people that no matter if they go into recovery, everything's going to be perfect, because guess what? If you don't pay your light bill and you're in recovery, they still shut off your lights. And people need to realize that it's still going to be hard. But if they have hope, if they have a good recovery support system, not a support system that just tells them to go do stuff, but a support system that has actually been there and held those 2x4s and helped them learn. When they have that kind of recovery system, guess what? When those things come up, they still have hope and they still have somebody that they can turn to, or they have the tools needed to turn to it. Next slide, please, ma'am. Recovery requires connection and belief. Now, one of the joys that I have with working with Native American tribes across the country is exactly that, connection with belief. All right, connection with belief, tradition, and culture. I love Native American culture. I like Native American culture from up north. I like it down south with the Pueblos. One of my sisters is Chris. She works with TLPI, and I love it when she talks about all that stuff. Well, thank you, Helen. I really appreciate that. We can talk more about that later too. Chris is my sister. She calls me her brother, and I would do anything for her. And I love learning about her culture, and I love being immersed in that culture. Recovery requires connections and belief. Now, I know that oftentimes some people might have different cultures. I'm Polish, okay? I am Polish, and most of my family is Roman Catholic, except for my dad, who suddenly decided that he didn't want to be Roman Catholic, and now he's Jewish. And that's what he practices, is the Jewish religion. That's fine. I love learning about that. So there's some people that are going to really embrace that Native American culture, but then there also may be others that look for a different belief system, such as through churches or other things. And it doesn't have to be a religious thing either. That's a big thing. I've talked with people that a belief system and a connectedness with nature, with hunting. You guys can't see it because I hid the background, but I have a sailboat that I'm usually on, and that's my connectedness. I am connected with the water. I love being on the water. I love being by the water. And that's my connectedness. That's my belief system. I'm at peace with myself when I am on my sailboat. And that's what I look forward to. And so recovery is going to require a connection with something, nature, religion, culture, all those different things. It could be family, connection with those things. That's where we can see where this connection and belief system can kind of tie in and really start helping people. But there has to be something there. And I think that also helps with when we talk about hope and purpose. That's what we see, is that hope and purpose is coming through. Next slide, please. 5 essential action steps. All right, here we go. We're going to talk about some of the essential action steps to get there. Get ready. That means be ready when they're getting ready to do this, and when they want to do it, get them ready. Have them set a date, get them ready for it. Break free. That's when we stop having them do it. The getting ready is pre-contemplation, if you want to use a clinical term. Breaking free is when they start moving forward. Break the connection. Break the connection. You got to break that connection and start new ones. Choosing the right path. That's that point where we have a choice about staying in remission, or you have a choice about moving into recovery. Now, dealing with temptation. Guess what, guys? Temptation is always going to be there. And they need to know that, and you need to know that. I quit smoking 15 years ago. When I used to smoke, I was a 3-pack-a-day smoker. I would get up in the middle of the night and go outside and have a cigarette. I still occasionally crave a cigarette. Occasionally, when something happens that triggers that brain, that neural pathway, because that's what we're talking about, neural pathways, I still will crave. Now, do I act upon that? No, because I've got a good support system. I have hope and all these things. And so I don't have to act on that. But I'll tell you right now, the reason why I started smoking, and it was 14, by the way, it was to be accepted. One of my friends smoked. And I thought if I smoked with him and the group of people, I'd be accepted. And it was. As soon as you start doing that kind of stuff, it's instant acceptance, But you need to understand that they need to have the tools to deal with temptation, and they need to understand that there's going to be temptation, There's going to be that temptation, and you need to help them work through it. So one of the things, and I know this is going to sound horrible, but one of the things you can do is have a relapse fantasy. So you sit down with them and you say, okay, tell me what your fantasy is about relapse. And if they say they don't have one, they're full of it. Because I'm telling you right now, when I quit smoking, I had in my mind that someday they were going to develop a healthy cigarette. And when they developed that healthy cigarette, I could start smoking again. And what happened? That darn vaping came out. And I thought for a minute, oh my God, it's here. It's finally come. The healthy cigarette is here. Thank God. I also realized that if I didn't have vaping, I would probably go back to nicotine and smoking. And so I didn't start. And I had a long point of recovery at that point. But that's that part of it is it gave me, if I would have had a tool to know that was going to come, that would have helped. So one of the things we talk about is trying to make sure that they go through their relapse fantasy or the remission fantasy, and then you start planning for it so that when it does happen, they're ready. So if my remission fantasy is that I'm going to be hanging out with these friends, and all of a sudden somebody's going to have something and I can use it once and everything's good, then you need to plan for that. So like, okay, if you're hanging out with these friends, there's an issue right here in the get-go. And if this happens, this is what you're going to do to help it. It's almost like having fire drills, so you make sure that they're ready for that. And it's essential that you make sure you do that kind of stuff. Okay. Next slide, please, Cindy. Recovery and recovery capital. Now, I already started talking a little bit about recovery and recovery capital. Next slide, please. Go ahead, Cindy. There we go. Okay. So we're going to talk about some languages of recovery, and we're going to talk about alternate terminology. Okay. So current terminology is treatment is a goal. Treatment is the only way into recovery. I can talk about that real quick. So let me jump on that real fast. I like it that you guys chat with me when I'm doing this. I know I should probably take questions at the end. Jordan's probably ready to kill me, but I do like it when you chat because it makes me feel like I'm there. So life trauma triggers that cause folk to quit resisting and go into remission. Okay, so hopefully when we're talking about being in remission, that's usually what we're talking about is when something happens and there's a loss and they go back into active substance use again. That's usually what happens. Most of the time, if they're in recovery, okay, when they're in recovery, they should have a pretty good support system already in place and have some ideas of values and morals that they don't want to break. So for example, if my dad passed away and I'm in recovery, the chances of me going and hanging out with my old friends should be low, you know, because I've already got new friends that can be here and support me. So I think the answer to your question is again, I think that most of the time, people think that somebody's in recovery when they're actually not in recovery, they're in remission. And I've had many conversations with people with substance use disorder when I talk to them and I say, you know, you're not in recovery yet, you're in remission. And they will get upset and they will tell me that NA and AA and everybody else has told them that they're not using, so they're in recovery. And they don't like hearing that they're actually in remission. But if they're still hanging out with the same people, if they're still around people that are making bad choices, if they're still doing the exact same life that they did before, except for they're going to meetings, then they're not in recovery, they're in remission. And that's why oftentimes people in recovery fall back into active use, substance use. That's one of the reasons why, you know, they will literally say, what is it? Use is part of recovery, you know, relapse is part of recovery. That's the term. Relapse is part of recovery. No, relapse is part of remission. It's not part of recovery. Okay. And it doesn't mean that people can't jump back in and out of remission and recovery. It can happen, but usually it's pretty rare because they should have those support systems. So I think a lot of times, like I said, I think most of the time people aren't in actual recovery. They're just in a very long-term remission. So treatment is the goal. Now, if you go over the alternate terminology, treatment is an opportunity for initiation into recovery. Treatment is not the only way into recovery. All right. That used to be the belief, is that treatment was the only way to get into recovery. You know, that's not true. I'm not saying treatment doesn't help. And I'm telling you right now, if we could get a year-long treatment program, our chances of getting people out of remission into active recovery would be much better. But there are some people that don't use that pathway, and that's okay as long as they're working towards it. Untreated addict, individuals not yet in recovery. Substance abuse, substance use disorder. Drug of choice, drug of use, because it's not a choice. It's not like they're going, I decided that I want to be addicted to heroin, you know, because otherwise everybody just be like, I think I'll just be addicted to something that I don't think is as harmful, like, I don't know, chocolate bars. You know, it's not a choice. If it was a choice, they would do that. It's a drug of use. It's not denial, it's ambivalence. It means they can't have the ability to think. And if you keep going through these, I want to make sure I'm not getting too far on time. We're good. If you start looking at just the change in terminology, think about that. When somebody comes in and I say, what's your drug of choice? I've immediately put all responsibility on them. I've made it sound like they wanted this life. This is where they wanted to go. And these are the drugs they wanted to use. And that's not true. If I say, what's your drug of use? That's a completely different thing now. Now we can look at this as a disease. We can start working with somebody. We can start helping. You know, again, clean and sober, drug-free or free from illicit drugs. Because if they're not using them, they're not clean. And think about that connotation of not being clean. You know, and again, relapse is part of recovery. No, reoccurrence, return to use may occur as part of the disease, but it's not part of recovery. It's part of the disease, and it can happen and take you out of remission or recovery and put you back into active use, but it's not part of it. Okay. And then again, reoccurrence, you know, or return to use. There's lots of ways to look at this if you go through these. Okay. Next slide, please. The most respectful. Oh, thank you. The most respectful way of referring to people is people as people. I am still working on this. So I don't want anybody to be hard on yourselves or hold people accountable. I still slip back into saying clients or patients or those kind of things instead of saying the people in our program or the people that come to my office. I'm still working on it, and that's okay. It's okay to be working on something as long as you're actively trying to change the way your mind's thinking and the way you're looking at it. You know, and wouldn't it be much better instead of calling somebody a client or a patient, saying the people that are in our treatment court or our people are on our healing to wellness court. And one of the great things is Native American population caught on to this before everybody else. That's why they're not called tribal drug courts. They're called tribal healing to wellness courts, because they seen that language had a difference and a connotation to it, and that's what they wanted, was healing to wellness. You know, again, if you look through some of these, Matthew is manipulative. No, Matthew has learned how to survive, and Matthew is really trying hard to get his needs met, and he's using the only survival tool he's had. You know, and that's one of those things that we can look at. You know, because we're taking the blame out of the statement. We're recognizing the person is just trying to figure out how to get something they need by the ways they've learned how to do it. You know, non-compliance. Maybe there's a way to do it differently. Say that Kyle would rather do this. Kyle is looking for other options. Kyle's choosing not to. And I know it doesn't seem like a big deal, but it really is, because it describes what it looks like uniquely to that individual instead of classifying them and making them seem like all this is just choice. You know, so I'm not going to read through all of these, but I want you to look at them and get an idea of what we're looking at here. You know, okay, next slide. How likely are people to recover? Well, when people are in recovery, they're very likely. And I know we can go over the different statistics. Some people say 1 in 10, some people say 3 in 10. 1 in 10, I think, is kind of the standard of what people are likely to say about recovery. I don't like doing that. I don't like using statistics that way, because I think when we do that, it's real easy to break somebody down into a number instead of a person. And I think that's a really dangerous thing to do, is to break somebody down into that kind of statistic. You know, I will say that people do recover, but they won't recover without hope. And that's what we've talked about all the way through this, is hope. And again, I don't know how to stress it enough about hope, but with follow through. I can tell my kids that I'm going to take them to see Santa Claus and give them that hope. But if I never get them in the car and drive them there, then what's going to happen? That hope's going to be like ash in their mouth. It's going to be something you promised and I never got. It's like Lucy in the football, you know, pulling it away. If you're going to give hope, you got to help them get there. You got to give them a ride. You know, you gotta walk them through that so they can understand that, and so they have an idea of where they're going and what they want to do. You know, next slide, please. Recovery happens. I can tell you right now, recovery happens. There's a whole bunch of people out there that have recovery, and we need to really stress that and work with that. And again, I think we need to make people understand that recovery is not going to happen without change. That if you don't change things, and again, give them the tools for the change, then recovery is not going to happen. You're just going to be on a long cabbage diet and remission, you know, trying to figure out why things haven't gotten better and why your life is still right where it's at, you know. And anybody wants to steal my stuff over at NADCP, that's one of the things we say is case, copy, and steal everything. You're more than welcome to use my analogies and all that stuff. And I'm hoping they help out. So next slide, please. Okay, let's understand recovery capital a little bit more. So I want to go through this a little bit at a time so we can make sure that we're getting close here. All right. This is the stuff you're going to have to initiate and sustain recovery from substance use disorder. Okay. This is going to be the sum of the person's total resources, or their resource capital. So we look at personal, all right? Their personal stuff that they're going to have, or social. Oh, go ahead. I heard somebody talk. I don't know how they talked, but they did. Okay, must have been somebody else. It's probably Cindy. Okay, so we have to have social. They have to have the ability to have social connection. Community, a community that's going to help lift them up and help them do what they need to do. Financial. If they're broke and living in a box, it's hard to have recovery capital. I'm sorry, I think there's a plane flying by. So give me 1 second to let the plane get past. Okay, hopefully it's better now. So again, that personal hope, that personal connection with people, you have to have that. Next slide, please, Cindy. Recovery management, helping people move on. That's the way we do it, guys. So at this time, I would like to take questions and kind of answer them and go through if anybody wants me to go into more detail about something or less detail, whatever you guys want. That's why I want to make sure that we have enough time to kind of touch upon that. So go ahead with your questions. And Jordan's like, well, Mark, you answered half of them while you were doing your presentation. I know, but there's got to be some more out there. Hopefully. No questions? Everybody wants to get for their next break and stretch their legs probably. Oh, well, thank you. Thank you, Terry. Well, that's very nice. Thank you, guys. I really appreciate it. One of the things I want to stress, if you guys liked the presentation, make sure it reflects in the evaluations. Putting down all good numbers is also good, but when you write a sentence, it makes Jordan read it. And he's like, wow, that guy Mark really must have did a good job because, you know, they actually wrote a sentence. So, okay, the question was, is it well known in the recovery world or in the clinical world? No, it's not. And that's one of the things that we're starting to do with education. We're doing train the trainers, where we're going around and we're teaching clinicians how to start switching that. You'll see it. It's slowly trickling in. That's why we're saying substance use disorder now instead of addicts. And so remission and recovery. So this is starting to come through. And I need to give credit here where credit's due. One of my bosses, Terrence Walton, is the one that actually created this presentation and wrote up all the material for it. And he's with NADCP. He's a genius. And so he gets the credit for that. So, okay. Any other questions for me? Oh, there's messages. I got to scroll down here now. Okay. Yep. Make sure you complete that evaluation, guys. Okay. Is there any more questions?
Got a couple here that were dropped into the Q&A box, Mark.
Okay.
So we'll start with one here. How do you help with someone that self-isolates?
Well, first of all, is you start educating them. Start educating them about what the isolation is going to do. And then try to make, now if you're a clinician, you can only do certain things, okay? If you're a family member, then that's where you can start, spending time with them, trying to get them around more people. As a clinician, usually that's an exercise that you're going to start doing, and hopefully the clinician will start working with them on how to get out. But again, if I tell somebody as a clinician, you got to go hang out with other people, I need a family member or another social, remember that social we talked about as part of the recovery? I need to know that there's going to be somebody working with that person, either a recovery management person or a recovery coach or a sponsor that's going to help them get connected where they can meet other people and get out, And so that's one of the things that clinicians, again, are real good about telling somebody to do things and giving them exercises, but then there's a little bit of a stop there because it's hard because we can't spend that much time. So does that answer the question, I hope?
I hope so. Otherwise, feel free to drop more questions or follow-up into the comments and Q&A. Couple more to hit you and pepper you with here, Mark. This one's great, really kind of getting into the finer details of this. But the question reads, so when you're dealing with someone in denial or thinks that marijuana is not addictive, what advice do you have to persuade them? And additionally, if someone does not have at least 6 out of the 11 of the DSM-5s, are they safe?
So I guess what I would start with is I would start with education. And then I would see part of the problem here is we've had 30 years where it's been illegal. And we've had 30 years of people saying, there's no harm. All the people that were advocating for it were going, it's not addictive. It doesn't do this. It doesn't do this. It doesn't do that. And that some of that might have been true, okay, back in the 70s. But the marijuana of the 70s is not the marijuana of today, first of all. Okay, the stuff today will mess you up quick. So there's one difference there. But what I always go back to is alcohol addictive? Is alcohol addictive? You know, and if I can get somebody to at least acknowledge that alcohol is addictive, then there has to be the potential that weed could become addictive, even if it's just a crutch, so you don't have to deal with feelings and emotions that you don't want to. You know, and that's the way I look at it, is that, well, if it's not addictive, then why do you have to do it? And you keep asking those questions. Why do you have to do it? Why do you have to do it? And try to see it, get them at least to acknowledge it. Now, if I had somebody that had 5 out of the 11, I would be worried. Okay. I'm not going to advocate marijuana use the same way I would not advocate alcohol use. So I'm not going to say it's somebody's safe to do something when I don't know the whole situation. Truthfully, I think that anytime we mess with that stuff, it's dangerous, you know? And I know that my brothers-in-laws, they have beer and they like beer. And that's great for them, but I'm not going to advocate and say there's not a chance that someday they might not become addicts, because I can't answer that, you know?
Yeah.
How do you,
Thank you.
got it now, Jordan. How do you install
Okay.
hope? Well, I think the first thing is you got to you got to show them what hope looks like. So if I'm at the end of my rope and I'm homeless living in a box, and you start getting me to go to the social aid and start seeing that there's things out there that can help me, then that shows hope, you know? And again, I don't think you can just tell people there's hope. You got to show them where it's at and how to get it. You know, you can't tell me to go to the DHS and fill out paperwork so I can get an apartment to rent. You need to literally take me there, help me go through the process, and give me that hope, you know? Again, our criminal justice system, the way our system is set up is not, it's reaction, just like our healthcare system. We react when something happens, we don't prevent. And so if we could start doing more prevention, or after somebody gets out of jail, doing prevention to stop them going back in, we'd be much further along than what we should be. Can I speak to any significant differences between the general population in recovery and ANONs in recovery? Yeah, I can. So, and again, this is my opinion. This isn't, I can't back this up with a scientific study or anything like that, but I will say that I think oftentimes in Native American tribal communities, it is harder with recovery because the substance use is so proficient, and it's actually been, I call it what's called Frankenculture, meaning that some of the substance use has actually been wrapped into the culture and accepted as a norm. One of the ones that I will use as an example of that is the 49er before a powwow. Up in Michigan, when they have powwows, the night before it, they have a thing called the 49er where everybody gets together and drinks, and that's become part of the culture of that powwow, which is sad because that's not anything to do with the culture of powwow, but that's that Franken culture that can be slip in and be acceptable. And so I do think it's more challenging just because of the generational trauma, the secondary trauma, and all those things that happen that prevent people from getting in the recovery process. And so that you have a smaller pool of those recovery people. And so more people end up kind of floating around in remission trying to find their way out. And I don't know if that helps or not, but that's kind of where I'm at. Does that help, Christine? As a judge, are there questions I can ask from them to help me understand whether one person is in remission or recovery? Yeah, there are, Judge Garo, who I love to death. There's lots of things. One of the things you can do is find out who they're hanging around with. You know, that would be a good thing. Just find out who their friends are. And if they don't have friends, then there's an issue. And find out if their friends are in recovery or remission. Find out if they have a place to live. Find out if they're paying their bills. Think about everything that somebody that would do that's in recovery, which would be healthy living. You know, do they pay their bills? Are they working? That's the stuff that we can look at and say, okay, this is what a functioning person normally does. If they're not doing that, then the chances are they're not in recovery, they're still in remission, you know? So if I'm not using, but I'm hanging out with the same people and I'm not working, or, you know, or I'm choosing not to work, then that kind of answers that. So, okay, I gotta switch back to the chat now real quick too. Okay, I got 2 things going on here. Okay, that's good. Thank you about the thing with the 49er. Any other questions with the Q&A? I think I've got them all right. Last thing I seen was Christine. I got Carrie. I Okay, I think I got everybody.
Yeah, I think you
So-
cleared it out, Mark.
Woo, look at that. See, I'm glad I gave myself a little bit of time for that too.
Mhm. Thank you
All
so
right.
much for that.
Hey, it's been a pleasure. I love working with you guys. I love working with Native populations, and anytime you want me to come around, let me know. And you know, the thing is with NADCP, we do tribal trainings, and if anybody wants to reach out, you can go to our website or go through Jordan, and we partner all the time with TLPI. And so, you know, so
Thank you
So-
again, Mark. I just have a couple quick reminders, or one big quick reminder for our audience who's still on the workshop. The survey link has been dropped into the comments and chat box. Please do complete an evaluation for this session specifically. We like to use those to improve our content and future events, and any additional comments or information is really helpful to us. So please do complete an eval if you have the opportunity. Now, recordings of this session will be available on the online virtual conference platform until July 30th. After that time, you'll be able to access recordings, all recordings from this training at enhancementtraining.org. And once again, that's after July 30th. So like Mark gave us a ton and a wealth of information today, and I'm sure many of you would like to revisit the materials in the recording. So feel free to replay that once it's posted up in the virtual conference space or at enhancementtraining.org. Once again, thank all of you for joining us again today. We will be reconvening tomorrow.